Laser enucleation for the treatment of benign prostatic hyperplasia has a steep learning curve due to the complexity and novelty of the procedure. Several training models exist but fall short on anatomic realness, including relevant anatomic structures such as the penis, tissue properties in both look and feel, and the ability to mimic the procedure closely to standard operating room procedure. We sought to design and validate a laser enucleation of the prostate model using 3D printing and hydrogel molding that improves upon existing model shortfalls. Expert endourologists and urologic clinic representatives were consulted to determine what existing models lack and what features are desirable in a new model. These items were then turned into engineering deliverables. Key features identified are less leakage than existing models, a distensible bladder, and a low-profile frame that will not damage the resectoscope. The model was designed in CAD software, then molds for the molding of hydrogel and the pelvis frame were 3D printed. The complete model can be seen here. It features a penis, prostate, and hollow bladder assembly, a pelvic floor with a section of rectum, and a section of pelvis that forms the boundaries for scope movement. The frame is able to be anchored to the table or bench to prevent movement during simulation. The two-part hydrogel assembly mold was designed to include the penis, prostate, and bladder in one continuous, watertight piece to accurately simulate irrigation and suction through the scope. To use the model, the trainee sets up the scope as they normally would during surgery. Here, the trainee is using a 550 nanometer holmium laser fiber. Lubrication is applied, irrigation is turned on, and the scope is entered into the urethra. The bladder is filled with fluid while the trainee visualizes anatomic landmarks. The trainee visualizes the inside of the bladder and looks for both ureteral orifices. Note that this model does not include that feature, but in practice, the trainee would identify them in a patient. The median lobe and verumontanum are identified next. The scope is pulled back to identify the external urethral sphincter, and the hypertrophy of the prostate is assessed. A groove is cut into the median lobe just proximal to the verumontanum. The groove is deepened then to the level of the capsule. In this model, the adenoma is yellow and the capsule is white to allow trainees to identify where they should and should not be cutting. Incisions are then made at the 5 and 7 o'clock positions, connecting to the first plane developed. These incisions are deepened, and any remaining attachments are then cut to free the median lobe. The median lobe can be pushed into the bladder to await morcellation while the lateral lobes are enucleated. As with the median lobe, the planes developed to remove the lateral lobes can be easily identified. The adenoma will not separate easily from the capsule with blunt dissection, encouraging trainees to identify and develop planes using the laser. Because the pubic bone in the frame is 3D printed with a rubber-like material, trainees can feel the anatomic limits of their scope movements while enucleating the most lateral portions of the prostate without potentially damaging the scope on a hard boundary. This model has been tested and works with either holmium or thulium laser fibers. 8 novices with less than 5 career LEPs and 1 advanced learner with 31 to 50 career LEPs performed LEP on the model at the NSAUA meeting in September 2024. Participants were asked to rate their agreement with the questions on a 5-point Likert scale after the workshop, with 5 being the strongest agreement. 3 questions were asked to evaluate face validity, and 7 questions were asked to evaluate content validity. Validity for this initial study was confirmed by a mean score for each question of 3.5 or higher, which the study team selected as a threshold before the workshop, indicating 70% agreement. Overall mean face and content validity were determined. Performance metrics such as total lasing time in minutes, weight of the enucleated hydrogel in grams, and energy use in kilojoules data were also collected for each participant. The mean response score for each question is shown in the figure. All of the questions asked received a mean response score greater than 3.5. The mean score for face validation questions was 4.26, and the mean score for content validation questions was 4.03. The participants had a mean total laser time of 26.51 minutes, enucleated 23.21 grams of tissue of the total 75 gram prostate, and used 47.716 kilojoules of energy. The mean percentage of the prostate enucleated was 32%. Operation efficiency was defined as the weight of prostate enucleated per minute, and on average was 0.98 grams per minute. The laser to prostate ratio was defined as the amount of energy used to enucleate a gram of prostate, and on average was 2.68 kilojoules per gram. Initial face validity has been confirmed for this LEP model using 3D printing and hydrogels based on surgeon and clinical representative design requirements. The results suggest the model will have content validity when reviewed by a panel of experts, as none of the trainees in the workshop population were LEP experts. The model simulates surgery well and can be an effective tool for teaching in a safe environment. The model can also be used to measure surgeon performance improvement over time by tracking metrics such as enucleation time, weight of the enucleated tissue, operation efficiency, and laser to prostate ratio. The next step is to perform a multi-institution validation study incorporating more expert feedback.